Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. The lecture of this day about the disorder of the cranial nerves. Objectives: to describe dysfunction and the clinical manifestation of the visual and the optomotor systems, and to approach the patient to the visual and the optomotor dysfunctions, and to describe functional anatomy of the cranial nerves and disease affecting them with the proper management of each cranial neuropathy. First, we start with the neuro-ophthalmology. Characteristic clinical disturbance result from lesion of the second, third, fourth, and sixth cranial nerve. Clinically, the optic nerve behaves as though it were primarily carrying central visual information. Therefore, lesions of the optic nerve may produce a combination of following: loss of visual acuity, diminished color perception, depression of the central field in a central scotoma, defective pupillary reaction to light. Third cranial nerve palsy. A complete third cranial nerve lesion causes ptosis and inability to rotate the eye upward, downward, or inward. When the lid is passively elevated, the eye is found to be deviated outward and slightly downward because of the unopposed intact actions of the lateral rectus and the superior oblique muscles. The lateral rectus will draw the eye laterally and horizontally and laterally, and the superior oblique will try to do intorsion of the eye downward. So the eye in third cranial palsy appear to be deviated laterally and downward. Since the preganglionic fibers lie near the surface, so the compressive lesions of the nerve dilate the pupil, which is called surgical third nerve palsy. But infarction of the central portion of the oculomotor nerve, as occurring diabetic ophthalmoplegia, may spare the pupil, which is called medial third nerve palsy. Fourth nerve palsy result in extortion and weakness of downward and inward movement of the affected eye, most marked when the eye is turned inward. So the patient commonly complains of special difficulty in reading or going downstairs. Head tilting to the opposite shoulder is especially characteristic of fourth lesion. This maneuver, it is a characteristic maneuver called Bolshevsky maneuver. This maneuver causes a compensatory intorsion of the unaffected eye and ameliorates the double vision. Lesion of the sixth nerve result in paralysis of central and or outward. Lesion of the sixth nerve result in paralysis of lateral or outward movement. With incomplete sixth nerve palsy, turning the head toward the side of the parietic muscle may overcome diplopia. Now we talk about the visual loss. The visual pathways represent 1/3 of supratentorial brain mass and are frequently affected by structural lesions and a wide range of neurological disorder. The most important part of evaluating a patient with visual loss is to establish whether the visual loss is monocular or binocular, painful or painless, the temporal profile, which means onset, sudden, acute, subacute, or chronic, the course transient or permanent. Monocular visual loss results from lesions anterior to the chiasma, means prechiasmal, the eye itself or the optic nerve is affected. Binocular visual loss results from either bilateral prechiasmal lesion or more likely from a chiasmal or retrochiasmal lesion. Diplopia. The majority of normal eye movements are conjugate. That's to say the two eyes move in an equal distance in the same direction. So diplopia arises from misalignment of the eye, meaning that the image is not projected to same points on the two retinas. As its most subtle, it may be reported as blurred rather than double vision. The monocular diplopia indicates ocular disease, while binocular diplopia suggests a neurological cause. Closing either eye in turn will abort binocular diplopia. Sequent and diplopia are features of nuclear and infranuclear lesion. Diplopia can be analyzed by measuring the direction of separation and the distance between two images. Clinical approach to a patient with diplopia. The most important part of the history when evaluating a patient with diplopia is to establish whether diplopia is binocular, horizontal or vertical or oblique, temporal profile, the onset and the course, fluctuating or constant. The cover and cover test is useful to localize the affected eye by reappear of one of the two images. The false image is the peripheral outer image. The false image is always coming from the affected paralyzed eye. Now, nystagmus is a repetitive to and fro movement of the eye. It may consist of smooth oscillation of the approximately equal velocity and amplitude, which is called pendular nystagmus, or it may consist of alternating slow drifts, which is called slow phase, in one direction and a corrective, resetting saccades, called the quick phase, and the other, it is called jerk nystagmus. Nystagmus points should be determined for the description. First, the symmetry, the direction, the position of the eye which exacerbate or provoked nystagmus, right or left, upward or downward, and last, the amplitude, fine or coarse. Now we talk about the optic nerve disorder, the concept of optic neuropathy. The types of optic neuropathy: inflammatory, vascular, compressive, toxic, hereditary, traumatic, elevated intraocular pressure, or elevated intraocular pressure. The classical features of optic neuritis or optic neuropathy: decreased visual acuity, visual field defect, relative afferent pupillary defect, can see the optic disc in the fundus by the fundoscopic or thermoscopic examination, swollen or shrinkage optic nerve, which means the change in the shape of optic disc, color, margin, and vessels. Optic nerve disorders. Optic neuritis can be classified into two types: anterior optic neuritis or papillitis, or retrobulbar neuritis. This slide shows feature of optic neuritis. Optic neuritis is common inflammatory disorder of the optic nerve. Females more than males are affected, and ocular pain, especially with the eye movements, is very common. Optic neuritis is general term used to describe involvement of the optic nerve when there is a swelling of the optic disc. In the terms of anterior optic neuritis or papillitis have been used when the clinical history and examination suggest optic neuritis, but the optic disc appears completely normal. The term will become retrobulbar neuritis is used. Optic neuritis is usually idiopathic, but it is occasionally caused by contiguous inflammation of the meninges, orbital or paranasal sinuses, and may also be caused by TB, syphilis, and fungal infection. Optic neuritis is a common manifestation of multiple sclerosis, but in patients who has no past history of neurological dysfunction, the diagnosis of multiple sclerosis is not justified. The majority of cases occurs in patients 20 to 40 years old and is unilateral. In patients less than 20 years of age, optic neuritis is commonly bilateral. Visual loss may develop very rapidly, but usually progresses for several days to weeks, and an aching orbital pain exacerbated by eye movement is common. So the treatment is occur with high dose of intravenous methylprednisolone, makes the recovery of visual function occur more rapidly. Vision usually begins to improve within 2 weeks. and most patients experience good visual recovery. Papilledema. This connotes bilateral optic disc swelling from raised intracranial pressure. Headache is a frequent but not invariable accompaniment. This is a fundoscopic picture. See the large diameter vessels. This is the veins. It is highly congested and the disc margin is not clear. It is blurred. There will be transient visual obscurations. Visual acuity is not affected unless accompanied by macular edema and hemorrhage. The blind spot is enlarged, and if the intracranial pressure is not reduced, secondary optic atrophy and loss of vision eventually occur. Optic atrophy. Optic atrophy is not a disease. It is a morphological sequelae of any disease that causes damage to the ganglionic cells and axons, which are first order neuron. Optic atrophy developed 4 to 6 weeks after the onset in the visual loss. The optic atrophy can be divided into a primary and secondary. Here in these pictures, picture to the right is primary optic atrophy, which follow acute or chronic lesion of the optic nerve or retina. The disc look like chalk white, chalk يعني نقصد مثل الطباشير, with cookie cutter sharp borders. The picture to the left, secondary optic atrophy, which follows papilledema. The disc is gray with shaggy borders from connective tissue proliferation. Now we finish the neuroophthalmology. We start now with disorder of the trigeminal system. If you take a look to this figure, you see the trigeminal nerve and its 3 branches: the ophthalmic division called V1, the maxillary division V2, and the third division V3. First, trigeminal neuralgia is a facial pain syndrome of unknown cause. It is due to microvascular compression of the nerve by aberrant loop of superior cerebellar arteries, or on occasion a tortuous vein is believed to cause the disorder. Aberrant loop mean يعني aberrant بالعربي mean زائغ, يعني ما ماشي بطريقة. فيما superior cerebellar artery or on occasion tortuous vein is believed to be the cause, compressing on this nerve. Pain is confined mainly to the area supplied by the second, mean V2, and third V3 divisions of the trigeminal nerve. Lancinating pain characteristically occurs and spontaneously abates. There may be a coexisting continuous deep dull pain. Sensory stimulation of trigger zone above the cheek, nose or mouth by touch, cold, wind, or talking or chewing can precipitate the pain. The physical examination is usually normal and the image is usually normal, but it appears that MRI should be obtained in the following groups to rule out a mass lesion or multiple sclerosis, because similar pain may occur in multiple sclerosis when there is a plaque of MS, the trigeminal root, or brainstem tumors, and these possibilities should thus be considered in young patients and in all patients with physical neurological abnormalities on examination, or in patients with no response to medical therapy. Remission of symptoms can be achieved by carbamazepine. Tegretol occurs within 24 hours in such a high percentage of cases that some believe it to be diagnostic. The alternative of carbamazepine is triliptal, oxcarbazepine. Phenytoin also tried. Baclofen, gabapentin, lamotrigine are also used. If the medical treatment is failed, there will be microvascular decompressive surgery, and lastly, gamma knife radiosurgery of trigeminal nerve root is also can be used in drug-resistant cases. Postherpetic neuralgia, herpes zoster or shingles, a vesicular skin eruption in the dermatomal distribution due to reactivation of varicella zoster virus in patients with a history of varicella infection, which is called chickenpox, where the virus remains latent in the dorsal root ganglia and the cranial sensory ganglia, with reactivation of vesicular skin eruption in dermatomal distribution, accompanied and followed by local pain and tenderness, most frequently involving the thoracic segment and ophthalmic branch of the fifth cranial nerve, which is called zoster ophthalmicus. It usually occurs after age 50 and becomes increasingly common with advanced age in immune-compromised patients and in patients with certain malignant disease like leukemia, lymphoma, and the incidence rate of 3.6 per 1,000 patient years. Herpes zoster is followed in about a third of patients by postherpetic neuralgia, which defined as a pain persisting more than 30 days and develop after the rash of the shingles resolves. The postherpetic neuralgia is characterized by constant burning hyperpathic pain, and the frequency increases with the age. The postherpetic neuralgia subsides within 6 to 12 months in many patients, but in 50% of those over 70 years, the pain persists, and it occurs in same dermatomal distribution as the previous bout of herpes zoster. Careful testing of painful area reveals decreased cutaneous sensitivity to pinprick. The other major complication of trigeminal herpes is decreased corneal sensation with impaired blink reflex, which can lead to corneal abrasion, scarring, and ultimately loss of vision. The intensity and the duration of the cutaneous eruption and the acute pain of herpes zoster are reduced by 7 to 10 days treatment with acyclovir. Corticosteroid also reduce the incidence of acute herpetic pain. Tricyclic antidepressants such as amitriptyline may be more effective when combined with phenothiazine or opioids. If you start a low dose of tricyclic antidepressant within 48 hours of the onset of the rash and continue for 90 days, this may reduce the incidence of acute herpetic pain and postherpetic neuralgia. Pregabalin and gabapentin can also be used, while topical application of capsaicin cream, which act as a transient receptor potential action channel antagonist, to deplete pain mediating peptide, which is called substance P, from peripheral sensory neurons, can also be helpful but is poorly tolerated. In otherwise intractable cases, weekly intrathecal administration of methylprednisolone may reduce the pain. Now, facial nerve. The seventh nerve is important mixed nerve with motor, sensory, and autonomic division. The examination of motor division starts from the top and work down. Have the patient wrinkled forehead, frontalis muscle, close eyes tightly, orbicularis oculi, show their teeth, ovaccinator, and pursed lips or blowing orbicularis oris. A lesion of the nerve trunk or its nucleus produce a lower motor neuron. Palsy, it affects all the muscles partially or completely supplied by the nerve. If there is weakness of upper motor neuron distribution, get the patient to smile with the upper motor neuron lesion. Automatic or emotional facial expression will be more complete than movements to command. Bell's palsy, facial weakness of the lower motor neuron type caused by idiopathic facial nerve involvement outside the central nervous system, and its account for up to 70% of facial neuropathy. The cause unclear, but the disorder occurs more commonly in pregnant women and diabetic patients. Increasing evidence suggests that the early activation of herpes simplex virus type 1 infection in the geniculate ganglion. The facial weakness accompanied by pain above the ear, and according to the site of involvement, there may be impairment of taste, lacrimation, or hyperacusis. Most patients recover completely without treatment, but this may take several days in some instances and several months in others. A poor prognosis for complete recovery is suggested by severe pain at the onset and complete palsy when the patient is first seen. Treatment is with antiviral agents alone is not effective as corticosteroids, but the combination appears to be more effective than steroid alone. It has to be begin within 5 days of the palsy, and artificial tears and ointment to prevent exposure keratitis, and the eye should be taped shut overnight. About 80% of patients recover spontaneously within 12 weeks. Even if recovery is incomplete, permanent disfigurement or some other complication affects only about 16% of patients. Many people with Bell's palsy recover completely without treatment, as we said. Ramsy syndrome, it is defined as facial neuropathy accompanied by erythematous vesicular rash of the ear, so-called herpes zoster oticus, or vesicular rash of the mouth. It may count for up to 18% of facial neuropathies and will be mistaken for Bell's palsy if the external auditory canal, mouth and tongue are not examined for vesicles. Unlike Bell's palsy, in Ramsay syndrome, other cranial neuropathies can occur. So involvement of 8th, 9th, 10th cranial nerve are frequent, with up to 53% of adults suffering hearing loss, which did not improve in 38%. And tinnitus and vertigo are also common. Treatment with oral antiviral dosages differ from what is effective for herpes simplex virus type 1 in Bell's palsy, so it requires more higher dose and longer duration. Glossopharyngeal neuralgia is an uncommon pain syndrome present with either a paroxysmal pain that is identical in quality to that of trigeminal neuralgia, or a continuous burning or aching discomfort. The pain is localized to the oropharynx, the tonsillar pillars, and the base of the tongue or the auditory meatus. The trigger area are usually around the tonsillar pillars, so the symptoms are initiated by swallowing or by talking. Paroxysm of pain may be accompanied by syncopal episodes caused by transient bradyarrhythmia. طبعا you know this is due to vagal stimulation. The women are affected more often than men, and symptoms begin at a somewhat younger age than in trigeminal neuralgia. As we said, neurological examination reveals no abnormal sign, and the application of local anesthetic to the trigger area may block the pain's response. There will be a trial with carbamazepine or oxcarbazepine. Therapy usually produces dramatic relief, and microvascular decorporation has been used. Neurootology. The vestibulocochlear or eighth cranial nerve has a purely spatial sensory efferent function. The nerve has two components, the cochlear nerve that detects the sound and the vestibular nerve that detects head and body motion. Dysfunction of auditory system manifested by tinnitus and hearing loss. The deafness divided into two types. Conductive, the pathology limited to the external auditory canal or middle ear, and the sensory neural deafness, the lesion involving the cochlea and cochlear nerve and the central auditory pathways. The vestibular system. The vestibular apparatus is the sensory organ for detecting sensations of the equilibrium. The bony labyrinth encasing the membranous labyrinth, which consists of three-dimensional angular velocity transducers, which is called semicircular canals, and the 3D linear acceleration transducers, which is called otolith. The primary vestibular efferents transmit information mainly to the vestibular and nuclear complex and the cerebellum. There is an extensive connections between the vestibular and nuclear complex, cerebellum, ocular motor nuclei, and the brainstem reticular activating system, which are required to formulate appropriate efferent signals to the extraocular and skeletal muscle. The vestibular nucleus sends outflow to the ocular motor nuclei, spinal cord, cerebellum, and vestibular cortex. Projections to the cerebral cortex via the thalamus provide conscious awareness of head position and movement. Approach to the diagnosis of vertigo. First of all, define the symptom. The vertigo is typically described as spinning, rotating, or moving. It is a false perception of movement rather than either of the patient or of their surroundings. Second, the duration of the illness. Third, temporal profile, continuous or recurrent. If it is episodic, what is the duration of the attacks? Fourth point is the differentiation between central and peripheral vertigo, which is lead us to the anatomical diagnosis. So in this table, the manifestation, the brainstem or cranial nerve signs usually present in central while it is absent in peripheral. The auditory manifestation is usually not present, absent in central causes of vertigo, while it is frequently occur in peripheral vertigo. The autonomic symptoms like nausea, vomiting, and diaphoresis, it is plus minus in central, while it is mostly occur in peripheral. The severity, the central vertigo is characterized by mild to moderate severity, while it is severe and distressing in peripheral. The effect of eye closure, it is not effective in central vertigo, while it is very effective and suppress the vertigo in peripheral. The nystagmus, It is maybe horizontal, rotatory, and can be vertical. It is multidirectional in central vertigo, while it is almost always unidirectional and never vertical. The course is persistent in central vertigo, while it is episodic in peripheral. The position of the head. The term positioning, which means with any movement of the head, this occurs in central vertigo. So the central vertigo is aggravated by any head movement, while in peripheral vertigo it is positional, means movement of a head to a special position. The final aim is to make a specific diagnosis. The recurrent vertigo is almost never due to a serious neurological problem. It is almost always due to one of three basically oral conditions. Oral mean ear problem, benign positional vertigo, Meniere's disease, or migraine. The more prolonged, severe episodes of vertigo that occur with a vestibular neuritis can last 4 days, and this is also characteristic for vertigo originating from multiple sclerosis or infarction of the brainstem. Patients presenting with chronic dizziness, general medical problems such as hematological, cardiac, and metabolic should be excluded. Then examine the gait and the autonomic nervous system before consider the vestibular cause. Lastly, the causes of central and peripheral vertigo. First, perivestibular disorders causes: benign positional vertigo, Meniere's disease, vestibular neuritis, head trauma, toxic vestibulopathies. The central vestibular disorders, the causes are Wernicke encephalopathy, vertebrobasilar ischemia and infarction, posterior fossa hemorrhage, multiple sclerosis, migraine. Treatment of acute and recurrent episodic vertigo is first bed rest, 1 to 2 days maximum, and vestibular sedatives such as prochlorperazine, cinnarizine, and betahistine. Thanks.